I'm sitting here with Luke Nelson, and I was introduced through Chris Johnson after I did that podcast with him, and he just put us in a group message and was like, "Hey, I think you should do a podcast with Luke." So here we are. Tell everyone who you are.
Thanks, Jake. Well, as the saying goes, a long time listener, first time caller. So it's been great to. I've been an admirer of your the content you've been putting out, and so a real honour to appear on it myself. So I'm a sports and exercise chiropractor here in Melbourne, Australia. I've been in practice for 20 years now. So I'm primarily clinician, but also running coach as well too. And so as a result, I see a large proportion of my patient base are runners. So I do sort of immerse myself with runners and primarily distance runners. But see also a mix of lots of different sports in practice. So like a lot of our field sports like soccer, and we've got Australian football rules here as well. And then your gym junkies and generally just people that like to be active. So, and then I'm also a father and a husband. So I've got two kids, and between all those things, it keeps life very busy.
So your sport is distance running, right?
Yes, correct. Yeah, I actually just ran my 10th marathon a few days ago, so on the weekend. So thankfully that was my 10th and fastest. So I was able to nab a PB in there, and had quite a few of my runners running around there out on the course as well too, which was great. So it was a good weekend. The legs are still feeling a bit wobbly, so I'm happy I'm sitting down for this chat today.
As far as you were saying before off air, the tendinopathies you've experienced, what kind of things have you
Yeah.
gone through?
Yeah, well, I've probably through my running journey, so I've now here notching up 10 marathons, and I would have started to my first back in 2009, and over that journey, I've experienced most of the running injuries. I would have, I mean, the first was ITB. I haven't had any bone stress injuries, touch wood, so I haven't had any really nasty ones, and thankfully. Probably the worst injury that I had was actually patella tendon injury, and that was actually from basketball. That was I returned to basketball in my late 30s, so I grew up playing basketball, and so I certainly admire some of your videos and showing your hops there. But I grew up playing basketball and returned in my late 30s. I'm 44 now, and there was an incident in a game where I actually reckon I partially tore my patella tendon, and that resulted in, well, really, I had at least a week off running, but really should have had longer than that because it was pretty sore for quite a period of time. So that took quite a while to rehabilitate that. So that was probably the worst injury that I've had in my last 10 years. So I guess it wasn't really running, but it was basketball, and that taught me a lot, and that was only sort of 3 years ago. So I'd been in practice and seen a lot of these in the meantime, but actually experiencing it myself was something else. Achilles, I've had very mild Achilles, but I think I've been very smart with the management over the last my journey. I think I do practice what I preach, and so as soon as I find something coming on, then I will modify my training. So whether that's modifying what I'm doing in the gym in the strength, or whether it's something I'm doing from a running perspective, I've found I'm quite good with that. So that has resulted in then really not much time missed off. And then more recently, the most recent one I've had was a hamstring tendinopathy, and that was uh, last year. And I remember I'd been on a trip away with my wife. I had a marathon coming up that I knew was already going to be a bit of a condensed block anyway. So took the gamble, built up, and then it was actually recording some content for my socials and doing a lot of sort of explosive hops. And I pulled up the next day extremely sore in my hamstring tendon. And that took a good time to settle down. Like there would have been, and we always talk about tendinopathy taking its time, but that probably took a good sort of 4 or 5 months to really sort of get that under control. It didn't impact, thankfully didn't really impact my running. I had to modify things slightly, but I was still able to run quite well, but there was just this awareness there, and difficulty sitting down, and yeah, which is I've always said with hamstring tendinopathy, and having seen a lot of it over the years, that it's probably the one tendinopathy that I didn't want to get, just because I've seen how much people suffer with it, because it's one of these things that doesn't only impact you athletically, but it's day-to-day life. It's putting your pants on, it's bending forward to tie your shoelaces, it's sitting, like that's such a big proportion of our day is spent, for a lot of people, is sitting, whether that's driving the car, whether that's working, and then for entertainment as well. So I experienced that, and we had a family trip, a car drive, and I was just like constantly just wiggling around in that time, just trying to get off that buttock, and using cushions and towels and everything else to relieve it. All the stuff that I'd told my patients before in the past. So again, it was a good learning experience, and just unfortunate that yeah, that, as I said, it was the one I didn't want to get, and the one that I did get myself. So,
And you
but
think it came up? You said you were doing broad jumps, or
yeah, it was broad jumps and mainly it was broad jumps and bounding, and I was doing like triple hops, and I was doing lots of things, and it was stupid. Like I actually had some this time around, a few weeks before this marathon. I had some stuff that I had to film, and I'm like, you know what? I'm not doing this. I'm doing this after the marathon, so that, and just in case anything happened, to wrap myself in cotton wool. So it was, yeah, I think it was a combination of that, and I'd also done the day preceding that, I'd done a pretty solid long run with some marathon pace work in there. So it was a big run. And then I think, like we often find with tendons and or any injuries there, there's it's multifactorial. There's these layers that add up on top of it. And for me, that was, looking back on it, that was the straw that broke the camel's back, essentially, that tipped it over the edge.
yeah. So you're seeing a lot of distance runners with the hamstring
Mm,
tendinopathy. I
mm.
I kind of there was that one study on, I don't know who it was, on jogging versus sprinting, and it was like you're loading the Achilles a lot in both, but it was like the hamstring really gets the stress from sprinting. So
Yeah,
I
yeah.
from the outside I would be like, distance running, why are you getting hamstring tendinopathies? Do you why is that happening in distance runners?
Yeah, it is really interesting, and you're right, because it's Dawn's 2012 study is what you'll be thinking of there, and that shows that at slower running speeds, like at jogging, the demand on the hamstrings is 2 times body weight, whereas your calf and is upwards of 6 at that slow running speed. So it's really only until you get to sprinting does that demand go up to 9 times body weight. So it is one that, firstly, we can see it in sprinters, but it I think with the running, it's, even though it's a lower demand, it's just the number of loading cycles. It's 500 steps per kilometer. Sorry to talk in the metric system. 500 steps per kilometer, and distance runners are doing, some of their shortest runs will be 10, 12 Ks, and then working up to over 20 miles. So it's just the repetitive cycles, even though that it's not that the high demand is just doing it over and over and over and again, and often on a daily basis, and sometimes twice a day, if they're doing double runs. So I think that's sort of a question I've asked myself as well, because it's not per step, it's not the demand that we see in sprinting and high speed running, but they're just doing so much of it.
That I think I did a show with Karin Silvernagle, and she had I guess a way of thinking of like, when you get a tendon issue, is it like an overuse issue, like you were talking about there, you're overusing it, or is it like an overload? Oh, now I'm thinking like an overload, meaning you're going for a max effort vertical jump and you just like really strain your patellar tendon too much. Is that something you've thought about, of like, if a sprinter gets it, they're not getting the loading cycles, but like, is there, obviously the rehab probably the same. You got a hamstring tendinopathy, but it's like, I'm thinking of, why did this develop, and like, this person, did they just do pull on that thing way too much, versus this person way too much volume, you know?
Yeah, I think that there is. I think that there's, and I guess the unique thing. Well, not, I mean, I guess not so unique when it looks at if we're looking at the Achilles, because it's what we call an insertional tendinopathy there, because we've got with the how that tendon attaches and wraps around the ischial tuberosity out into the buttock there, it is susceptible to compression, much like the insertional Achilles is. And to some extent, the patella tendon can be too. So there's the position that can affect it. So if you're getting a lot of hip flexion, which we see in high speed running, and then combine that with a lot of force, you can get essentially a sudden tug in compression. And sometimes if that's powerful enough, and there's maybe some other preceding things going on through there in that individual, that sudden one off it may be enough to sort of set it off, and you get this reactive, that reactive tendinopathy, versus the distance runner where it's just like just a small tug bit by bit by bit by bit, and again combined with some other things, then that just that does accumulate over time. I like to, I mean, it might be a bit semantics, like in terms of overuse versus overload. I consider them sort of the same thing, but I don't like to use overuse because it sort of implies that, like in terms of then rehabbing it, it's like if I'm saying to someone, "Oh, you've overused it," then they're like, "Oh, well, then I just need to use it less." Whereas if I talk about, overload, then we can sort of talk about manipulating the load and also, building capacity around that. So it might seem a bit semantics, but I prefer the term overload versus overuse, just to, I guess, get in the head of the patient so that they understand that, that rehab and load management becomes a really important factor in managing these. Um, and it can be like I see. I mean, there's certainly the other issue that we see affecting that proximal hamstring is a tears to the proximal hamstring, and we do see that in distance runners as well. But that tends to be more a result of I guess that decline, I guess, in tendon tissue, over a period of time, that reactive tendon turns into degenerative tendon, which then becomes, you start to see some tears develop in that. So yeah, we can see things combined to that, but then we can also see, acute sudden tears. I don't tend to see those. Well, I think in distance runners, it can be on the background of tendinopathy where they've had this progression that then goes on to this. Um, Acute tears we tend to see more in a sudden forceful stretch condition, or if it is a really powerful contraction through there. So in your sprinters, in our field athletes as well, like with in Australia, we've got Australian football rules where they've got a kick and they can get tackled and they can bend forward, and I've seen a few that have been ruptured that way. But distance runners, the more it's you're more managing it as a tendinopathy rather than as a tear.
So what's the typical story of a distance runner coming in with proximal hamstring tendinopathy?
So usually they're going to come in and describe of buttock pain. So, they'll usually point around their sit bone area, so where they're sitting down to. The severity may be, it can be quite acute, especially if you're dealing with that really reactive stage where it's very sore. They can't extend their leg out in front of them, bending down to touch their toes. They can feel that real stretching in through there. The difficulty running. Sometimes, at worst case, they can't run because it's just so sore. But generally, most of them can, and like a lot of the tendinopathies, they'll come in and it's like, well, I can run, it might warm up a little bit, but then it gets to a certain point and I just can't do it anymore. They'll often complain of pain on other activities. So we mentioned before how much this affects sitting. So they'll sort of say, oh yeah, it hurts me to sit. I can't sit for longer than 10, 15, half an hour without having to get up. So that's a really common one. The location of the pain, so it's a little different. Like usually with patella tendinopathy and Achilles tendinopathy, we usually say, it's quite pinpoint pain. Like they can often point to it with one finger, and if it's not that, it's likely something else. With hamstring tendinopathy, it can blur a little bit. Like they can actually get some pain going down into the posterior thigh or coming up into the buttock there. So it can, and that's where, our differentials there, we've got to start to think of, well, okay, well, is this the hamstring tendon or is this some of the surrounding structures that could be irritated there? Because we've got with the hamstring tendon right next to it is the sciatic nerve. So you can have some interactions between the two. And that's when you can have some irritation of that sciatic nerve, which can send down the leg. But it's important to differentiate that from an actual sciatic nerve issue, which might be coming from the back or coming from the gluteals higher up, that's actually affecting that and referring down. So they're pretty much the main thing, yeah, main symptoms that we'll see.
Is that the main differential diagnosis, or are there other things that
Yeah,
could be
so there's
going
a
on?
there's a few things when we're looking around the buttocks. So probably the key, the most common when they are sort of pointing around that area. If you're going to put money on it, it's most commonly going to be hamstring tendinopathy, especially in a distance runner. Mind you, we can also see this in gym goers as well too. Like especially those that have done deeper squats or deadlifts, there can put pressure on that. So I've seen that, and this can also happen in active populations too. Like I saw this during our lockdown here. We had some very restrictive lockdowns here in Melbourne. I think, unfortunately, during COVID, one of the most restrictive in the world. But I actually saw this happen in sedentary people. I had a few patients come in that developed this just from sitting on their butt too much in that lockdown time. So it can happen with them too. But so some of the key differentials we want to look into that area. So most likely it's going to be hamstring tendinopathy. The second thing it can be is nerve related. So this can either be from the low back, the lumbar spine, more commonly, so that can affect, and you can have either referred pain or radicular pain. So actually, where it's really directly affecting that nerve that goes down there. Less commonly, you can have what's called deep gluteal nerve entrapment. So that's where the sciatic nerve actually gets entrapped within the buttock there, and that they'll tend to describe the pain being a bit higher in the butt. So rather than right directly on the sit bone there, it's a little bit higher, and then they can have some pain referring down into the thigh there. You can also have around the area, so around the ischial tuberosity there, you've got well, you can have bone stress injuries as well too. So bone stress injuries are the issue, which are rare. You can also have what's called ischiofemoral entrapment, which is basically where you get an entrapment of the nerve and the soft tissue structures between the pelvis and the hip bone, and that usually occurs when they're going into extension. That's quite rare, and I've really only seen that in runners, mainly in distance runners. And what's happening there is it's usually as they're going into extension, you get a narrowing of that space and a pinching in that area. So that can look quite similar because they're sort of really pointing towards that into that buttock region there. And then less commonly, you can see things like what's called a pudendal nerve entrapment, which is again a little bit of a different nerve that gets entrapped around through the low back and the gluteals there. And they're probably the main ones. Adductor tendinopathy, like the adductors and adductor magnus comes in very closely to that ischial tuberosity, or does attach to the ischial tuberosity, but it does attach adjacent to the hamstrings. And sometimes you can get some involvement there, although usually it's around a little bit more. They'll complain a bit more into the groin, but sometimes, and with my one, I did feel it sort of come around into the groin a bit too. And I have seen that happen before. So that's something you want to tease out as well. Is that adductor? Yeah, pretty much the main ones.
Is there what role does imaging have in this
Good question.
diagnosing?
In short, not a lot. Like with sort of a lot of tendinopathy, I mean, we can usually base this clinically, and what we're seeing on imaging doesn't really dictate the management for this. And in actual fact, there's quite a high incidence of abnormal findings in asymmetric, in asymptomatic people, and we know that from a lot of other research that's looked at other tendinopathy. Interestingly, there was a study I think earlier this year. I can't remember the authors, but looking at they found those that had abnormal changes in their Achilles and the plantar heel were actually more likely to develop issues during the season. So even though they were asymptomatic at the time of imaging, they were more likely to develop issues there. So potentially, even though we're seeing asymptomatic people with imaging findings, they may be more likely to develop issues down the track. So to my knowledge, nothing has looked at that in the hamstring tendon. It's unfortunately a pretty understudied area with hamstring tendinopathy. So imaging, no, it doesn't really, like, probably the only times that I have image these. In fact, I rarely would, but if we're suspecting a significant tear, but they're going to present very differently. Like that's a really acute, sudden onset, and with significant loss of knee flexion strength, and that's when I'd probably image those and send them straight for MR. But that's there. Otherwise, I don't often image these.
You said it's understudied. Why do you think there's so much work on patellar and Achilles, but there's not a whole lot? I mean, I was telling you, I get messages on proximal hamstring tendinopathy, and I'm just like,
Yeah.
I'm not go listen to that guy that has the podcast, Brody Sharp, I
Yeah,
think it is. I'm like, go listen to
yeah.
his podcast. He must have it figured out because he has like hundreds of shows. But yeah, why is this an understudied area?
It's a really good question, actually. I don't know the answer. I don't know the answer. There's a researcher in Australia, Anthony Nasser, who's doing his PhD on, or I think he's just completed his PhD on hamstring tendinopathy. But it's I don't know. It's something that probably as a diagnosis, like when I was going through uni 20 years ago, it was not really something we were taught much about, and so I think and I guess it's being a little bit niche in that it is more common in endurance athletes, and so other populations don't suffer it from the most. So therefore, maybe the money is not being distributed to that, and it's going into bigger injuries like the Achilles and the patella, which affect your jumping sports and your field athletes as well too. So perhaps it's an incidence thing that it's not as big as some of the other injuries, but we certainly see a lot of it, and as I said, especially in the running space.
This whole the sitting pain. So like I guess with
Mm,
the Achilles, you have that research on insertional, and they can wear the heel wedges, and they get can get positive results. Or like I guess patellar can get deep knee flexion, quad tendon. But like the gluteal tendon can get compressed, so like trying to avoid those positions, maybe rotator cuff. When you get that sitting pain, what are you doing? Do you look at that as a bad thing that you don't want that to happen, and you want to kind of
yeah,
let the
yeah.
tendon settle, or what's going on?
Yeah, it's pretty much like you would. I mean, I guess the similar being with a gluteal tendon there, in that that things like you need to avoid sitting with cross-legged with a gluteal, or that the sitting position there can definitely make a difference. So the same thing with the hamstring is that if it is constantly irritating, it's just going to provoke it, and you're not going to be able to not going to be able to settle that down. So options you've got there. Standing desks are thankfully becoming more popular these days. So getting them standing more, so getting them actually off their buttock. I unfortunately had a runner recently, and she had both an active plantar heel pain and also Achilles tendinopathy. Sorry, plantar heel pain and hamstring tendinopathy. And so, you know, unfortunately, standing time puts more pressure on the plantar heel, and sitting time puts more pressure on the hamstring. And so we just had to like just mix it up, just rotate like pretty much every 15, 20 minutes, just sit stand, so that we weren't loading one over the other. But it was pretty bad because both were pretty acute at the time too. So it was a difficult one to manage, but thankfully we got through it. The other option we've got too, so standing desk is actually just cushioning. So anecdotally they'll find that sitting on harder surfaces, so they're sitting on like stadium seating, which is hard bench seats, and it just doesn't feel very comfortable for them, and unfortunately as distance runners, we don't have much of a butt there. There's not a lot of meat behind there like you do see in your sprinting athletes and your field athletes, and potentially that's a reason as well, that there's not that protection from the overlying glute max to give you a bit of cushion your tush. So it's really exposing that ischial tuberosity. So yeah, sitting on cushioned surfaces where possible, and then even putting a towel or donut cushions and that sort of stuff to basically go put the pressure on the posterior thigh, and not be sitting right on that ischial tuberosity. And then sort of even leaning like can make a difference too as well too, because unfortunately sort of being more upright, that does put you directly on the ischial tuberosity where that does attach. So sometimes actually going into a more slouched position, so leaning back, is actually better for you because you're sitting more on your posterior, on your glutes, rather than on the ischial tuberosity. So that can pose some issues with potentially some aggravating the low back, but you just have to play a bit of tug of war there between taking load from one area to another. But it is a real problem though, yeah. And like I said, that's why this particular tendinopathy is a real nasty one, because it just impacts on daily life. And often, like the gluteal tendinopathy, you do have to get that part of it right, because if they're just pissing it off all the time during the day, if they're in a sedentary job sitting on it, it's not going to have the capacity to then be able to run, or reduce capacity to add more load on that with their running.
Are you giving advice too if they're getting pain bending down, like all the times you have to bend down during the day? Is that something you try to avoid, or?
Yeah, so it's sort of like I'm just thinking the cases where I've seen it in those that have got, because I have seen it in like tradies, like carpenters or plumbers and that sort of thing, where they have to get sort of in flex in different positions and get into crouch positions and shoveling, like that can be one where they're sort of stomping down the shovel there, like those sort of things. You do certainly need to consider you know occupational stress in their day. Like I think my approach to really all injuries is you've got to consider and yes, they're a runner, but they're a person as well too, so you've got to consider what's going on in the rest of their life. And looking at occupational stress, looking at daily stress, like life stress, all these sort of things are really important to ascertain from them, to figure out, all right, well, yeah, we've got a lot going on here. We need to modify some stuff on that. So I think, yeah, it's definitely you want to take a multifaceted approach, and it's not just simply a matter of manipulating their running loads and you'll be good to go. You do often have to address all these other things. And I know, a lot of your other guests have spoken about, the importance of that stress recovery balance. And I'm a big one for that. Like I always ask on my intake forms, how much sleep are you getting, averaging a night? What's your average stress level? What's your diet like? And so we're looking for sort of some potential things that can contribute to this. So to go back to your initial question, yes, I am, but it's not like for your average person that like, I guess, yeah, when you think about it, how many times you do bend forward to touch your toes, it's, for most people, it's probably not a lot. Like if they might put their shoes on and off, and they might drop something on the ground, but other than that, they're not bending forward a lot, and that can be an issue in itself. We can talk about that, maybe not being a natural movement habits, but a lot of people don't bend forward, so it's often not something I have to discuss too much with them. It's more the sitting. The sitting is really the big daily activity that pisses these off.
So that typical person, that distance runner, comes in with the hamstring tendinopathy, and like you've confirmed that, yeah, if you give that advice on getting rid of the compression, if that's aggravating, how are you starting the rehab for these
Yeah.
people?
So I guess we want to try, and as much as we can, we want to try and keep our patient involved in their sport. So if that is running, we want to try and keep them running if we can. And I do use Karen Silbernagle's that 4 or 5 out of 10. So if we can keep the pain, maintain the pain at that, then usually what we do from a running point of view is we will. Firstly, reduce the intensity, because we know before we spoke about that as soon as the speed goes up, so does the man on the hamstring. So if we can back off some intensity, try and keep the running a bit flatter, because we know that elevation also puts more demand. So if we're running uphill, that puts more demand on through the hamstring. So we reduce the intensity, keep the runs a bit flatter, and see what effect that has on it. If we need to then dial back the volume and reduce their distances, then that's also something we do. So firstly and primarily, we try and keep them running. And then secondly, I do quite a thorough assessment for my runners when I'm seeing them face to face. I test, we do a number of tests on their hamstring capacity. So we're looking at hamstring flexibility. We can talk a little bit about that in a sec, because runners typically have very poor hamstring flexibility. Um, we're assessing their capacity, but also looking at other potential contributors as well too. So looking at function of the lumbopelvic area, looking at trunk strength, hip abduction, hip adduction. So a lot of these things as well along that kinetic chain. And so once I've done that and I've sort of got I guess, a strength profile of that runner, then we know what we then need to target from that from a strength perspective. I guess then, like, most commonly, if we're seeing they've got a decrease, and I usually do a few different tests from a strength capacity for the hamstrings. But if they've got weakness in their hamstring, then obviously we want to start them on some strengthening through there. Now, I guess I used to use, like, going back, and it's interesting hearing all the other guests and talking about with isometrics, and I, again, going back to 2015 when Ebony Rio released her study on patellar tendinopathy, and the whole world went nuts with isometrics for everything, and I went down that boat as well too. So I did the same, and so I used to give a lot of long hold isometrics for to relieve pain. Sometimes it worked, sometimes it didn't, and now I will give, again, like if they're in really acute pain, I will give some longer hold isometrics to do during the day, if that helps with their pain. Yeah, I find it probably like some people are just like, oh, no, it doesn't really, I'm okay with it. Like, it doesn't, I'm not too worried about that. It doesn't really affect my sitting pain if I do those isometrics. Like, it doesn't improve that pain if I do those long hold isometrics. So probably find that they don't do that so much. I do though, and this is probably something that I've changed in my approach over the last few years now, being exposed to, the Berlin group with the shorter hold isometrics to improve tendon stiffness. I do use those in my rehab, and pretty much the protocol that as they use in with theirs with a shorter duration. And I will usually opt to do that in a hamstring curl, but there's a few options with the hamstring curl. So I think that hamstring curls do form a pretty staple part of a hamstring tendinopathy rehab. How I like to modify those. So there's two positions. So a seated hamstring curl is preferred because of the greater hip flexion angle. So if you can get a greater hip flexion angle, you can usually generate more force in through the hamstring, which then will in turn impart that through the tendon. The only caveat with there is that it's done seated, and we've talked about how much people don't like that with the hamstring tendinopathy. But because it's only a short period of time, like we're talking, it might be 30 seconds for a set, and you're only doing a few of those. Like, it's generally pretty good. Like, it's very rare that I've had that. Some gyms don't have that, so what I'll get them doing then is I'll get them into a prone position, but I'll actually get them to bolster up underneath. So even though some leg curls have got that flexed trunk, I'll actually sometimes bolster that up even more, so we can actually increase that hip flexion angle. Uh, and then I'll get them loading heavy in that. So if we want to work on their strength, I found their capacity is quite poor in that hamstring. We'll work on the strength there, but I'll also use that position for our isometrics, and I'll just do sort of basically just to switch from side to side. So we're just holding that, 3 seconds, and just alternating that through for the 5 repetitions. Probably the caveat there is you've got to make sure that high hip flexion angle is tolerated. So as we flex the hip more, it is putting more compression up into that proximal tendon, and that can irritate it. So we've always got to be careful about how much we ramp that up. So if they can tolerate it, I'll get them into a flex position to begin with. If they can't, I'll get them prone with their hip in neutral and just start working on getting some capacity in that regard. So that's a pretty big staple for me. Is a lot of the time I'm finding they are weak, and I guess that also is a reflection of distance runners in general, in that they know they should be in the gym, but a lot of them aren't, and so that they are a bit below the benchmarks that we like to set from a strength perspective. So that's going to remain in their program to help to get that up, and then, as I said, twice a week on the ISOs to improve stiffness there. It's an area, again, like, understudied. Nothing's been done on it. Nothing's been done even on the. I've looked at for the percentage of strain in the hamstring tendon. I can't find anything on that there. So we can only, I guess, extrapolate what's been done with the Achilles and the patellar tendon, even though they're a little bit different. But yeah, hopefully someone out there, and someone maybe listening to this podcast might be interested in looking into that. So that's the early stuff. So early hamstring specific stuff, and then incorporating that, I guess, into your more compound movements. So again, I like to get my runners lifting heavy. So looking at introducing deadlifts and squats. But the thing that we will need to modify with that is the range initially. So lifting off the floor for deadlifts will often be a bit provocative. So we might put them on blocks, or do some rack pulls through there. Then progressing the range as they get better, to be lifting off the floor. And then with our squats, again, opting for more front squats, which are a little bit more sort of anterior chain and quad dominant, but we've got more a vertical trunk there, and then progressing them onto to back squats, and getting more trunk flexion. Then looking at sort of hip flexion strength hip extension strength as well. So looking at things like glute ham raises and Roman chair hip extension exercises, to work on that. So basically, we're starting them early to avoid hip flexion. And the really, really angry ones, we might even start them doing some glute bridges, and some weighted bridges again, trying to load them up as heavy as we can. Like I'm not one for like, oh yeah, just do 10 of these and you'll be, without any weight. It's like, well, they can do 20 of them. So, we really want to put some load on it as early as we can. Um, Nordics, I don't actually tend to use Nordics for runners for a couple of reasons. One is that they are often runners not being the strongest. They often perform them quite poorly. Uh, and two is it's interesting actually this year, the start of this year, Steph Layachuk, she looked at some research looking at the Nordics and also hip extension exercises. And what she found is that they are good for, I mean, you're obviously improving fascicle length in the hamstrings and getting hypertrophy in the hamstrings, but it doesn't do a lot actually for the tendon and for the aponeurosis. So for the intramuscular tendon and the free tendon. So it's actually not the best exercise to improve that. And that's why I think, again, extrapolating that again into the Berlin group's work is that I think that, you can do your hamstring curls to get hypertrophy and build strength in through the muscle, but then your isometrics and high strain isometrics are designed to then affect the tendon. So I think, again, like what we do for, the other with our patella and Achilles, work on the muscle, have a muscle, an exercise to work on the muscle, have an exercise to work on the tendon. So, and that's sort of, yeah, I guess combining that research, nothing that's been published on it, but again, I'll roll with it, and it's been, getting good results, and hopefully, yeah, someone does the research someday to say either yes, that's good, or no, it's not.
So pretty much straight away, you're doing Berlin method.
Yeah, 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 and finding it again, like. And the same thing we find too that they talk about, like sometimes they don't have the capacity in the I mean, they talk about having the capacity in the calf to create that strain on the tendon there, and so we do sometimes see that, and in that they're pretty weak. And so even at the max force, that they're not getting a really high sufficient strain in that hamstring. So we need to build that up as also we build up that tendon, and generally finding them tolerated pretty well. Again, we're using, Karen Silverknuckle's pain guide there for all our rehab. So for our running and the rehab with that 4 or 5 out of 10. So I actually haven't, it's actually been quite rare for things to get really cooked, like really flare them up after introducing these exercises. I've found that they probably get more aggravated when we're looking at sort of pushing things from a deadlifts or a squats point of view. So, going quite heavy on through there. Um, and then as we're sort of going into more dynamic stuff as well too. So I've got, obviously building on your maximal strength, but then working into sort of explosive strength, like I said in how I injured mine, looking at things like bounding and broad jumps, which we know from Kotsapakis' work that horizontal propulsion, you do get more contribution from the hip through there. So looking at plyometrics in a forward movement. So early on, we might do some vertical, which is a bit more of an even contribution from hip, knee, and ankle, and then progressing them on to horizontal plyometrics through there. So. Yeah, I haven't had too many, thankfully, that have really got flared up from the strength work that we've given them.
Yeah, that's interesting. I had never heard of using Berlin the way you do for the hamstrings. I
Mm,
guess there's really nothing out there on that. I've got that question on it for the patellar tendon because I've always been like, if I did Berlin method, I think it would just blow up my patellofemoral joint and not feel good. And for people with really bad patellar tendons, I'm like, they even get a bad response from like 45-second isometrics. So I go even lighter and try to lighten the load and really get it to hit the muscle and lay off the tendon. I haven't thought the same with the Achilles. I've been like, I feel like the Achilles could tolerate a pretty high load pretty early on. Yeah, I don't know if you have any thoughts there on kind of what my thoughts are with the Achilles and patella versus what you're seeing with the hamstring.
like I've found it, yeah, probably like you, I've found the Achilles less likely to flare up with that protocol. I have seen it with the patella. anecdotally, for me, like when I did mine, I found the isometrics were quite good, but there was a warming up that needed to happen. Like the first few were quite, the first one or two were quite sore, but it sort of really did feel better after that. I mean, I had really bad, like when I did my that patella tendon, I had that what we call the tendon tremors, where I was fasciculating, like I was trying to hold the weight, and it was just that stuttering, which I had to, is not a good thing because essentially, and I think have you had Seth O'Neill talk about that before? Have you had Seth? No.
I haven't. No, I've
Um,
been trying to.
but
I've
Seth,
heard it though.
I
I've
mean,
heard of it. Yeah.
yeah, so basically it's just a rapid contraction. You do see it in yeah, don't tend to see it so much in the hamstring, but do tend to see it in the quad and the calf, where it's just that rapid fasciculation there. They're almost shaking, and that's not a good thing because essentially what's happening there is it's basically rapid shortening and contraction in there, which is essentially tugging on that tendon. So you really don't want that. So, but I did have that. I had that early on when I did my patella tendon. So I was sort of careful with how I did that to try and avoid those fasciculations. But yeah, it's I yeah, like you, I have seen it. If it's more likely to upset, it's probably going to be more into the patella than the Achilles. Why that's the case, I couldn't tell you because even I mean you like from a force perspective, you're putting a lot more through you're putting a lot more load when you're doing the calf and the Achilles, considerably more load. So yeah, I'm not too sure what it is to be honest, but don't tend to see then that flare up as much as with the hamstring, thankfully.
Yeah. Um, as far as when you get the patellar tendon, you got the quad muscle gets wasted away, I guess, with the Achilles, the
Mm,
calf. Did you
mm.
see that with the proximal hamstring, the muscle wasting?
Yeah, you can, and sometimes you can see also, whether that's more medial or lateral atrophy as well too. So, I like to just as an observation, like you can just do a resisted, have them just pulling up into like they're prone, pulling up into your hands, so doing like a hamstring curl on both sides, and you can just sort of look at the bulk between the sides, and especially those that have had it quite chronically, you can see some atrophy there, and it can be. You might see it more medially or laterally in the biceps fem there, that might be wasted away. I'd say. Yes, I'd say like you can see in the calf and also into the quad too. You can see that effect into the hamstring.
When you're doing these leg curl variations, are you looking at if the foot's turning out or the foot's turning in or yeah.
Yeah, yeah. So that's one as well too. That if you want to, and it's interesting, like with the actual pathology of this condition, they've found that studies have found some conflicting things. There was a study, Lempen and that I believe it was that found that it was 100% of the time. So they did, in surgery exploration there, they found 100% of the time it was affecting the tendon of the semimembranosus. So that's what the one that wraps underneath the joint tendon there, the biceps and the semitendinosus, wraps underneath and attaches more laterally on the ischial tuberosity. So they found 100% of the time it was affecting the semimembranosus, which is one of those medial hamstrings. But then another study found that it was pretty mixed, that it could affect any of the tendons through there. So it's sort of an interesting one that I've got, and because I'm not imaging these all the time, I can't confirm whether it's one or the other. Like you could in theory, if you had the imaging and found that it was affecting more the semimembranosus, you could then potentially say, all right, well, I'm just going to target the heck out of that sort of that medial hamstring group, and have that foot internally rotated to bias more the inside. You can also test that too, like test that with with the handheld dynamometer, which I do, which you can test them in neutral, test them internal rotation, test the foot in external rotation, and compare the differences between those. Arguably, you might find though that lateral hamstring is weak, and that then because then the medial hamstring is doing all the work, that becomes then the problem too. So it could be a combination of any of those things there. So yes, that is something I am considering with the foot placement. Most of the time most of the time for rehab, I'm having the foot in a neutral position because we can't confirm with any certainty that it's which tendon is involved. But if I am seeing, yeah, particularly atrophy in the medial or lateral, I will bias that in the rehab.
So you talked about that pain guide or pain guided activity thing.
Yeah, yeah.
The you talked about reducing the intensity, keeping the running flatter, and like seeing the effect. As far as the frequency, yeah, where are you at with the frequency of running? Do you tell them to take a day off or anything like that, or?
Yeah. Well, and typically, I mean, we know from the tendons that they can take that 48 hours to settle down. So I guess a really reactive tendon will have that day in between. I mean, most of my runners are running at least 4, if not 5 days a week, and some running 7 days a week. Some don't have a rest day. So some can tolerate it. And again, this is where it's an individual case by case basis where we test it and sort of see, all right, is it handling that? Like, do we need that extra day off? Because if that does, that significantly does cut down the amount they can do. Because if you're going day on day off, that's really only 3 days a week they can run. So, and for a runner that's doing high mileage, that's not great. And especially if you're going to be then again limiting it to 10 or 12 kilometers a day, less than 10 miles, they're not going to be too happy with that. So again, you've got to sort of find the balance between what they can handle. But yeah, like other tendons, sometimes a really reactive one will need that day off.
As far as the frequency of your rehab, is it 2 times a week, 3 times a week, or what are you at?
Yeah, generally too. Like it's usually a bit of a harder ask to get the distance runners doing more than 2 times a week. They're often doing none. So getting them up to do more than that is a bit of a challenge. If they've got like if they're significantly impaired, like they're really quite we've got a lot of stuff going on there, and they need to invest a lot more time, then I'll encourage to go up to 3. And if we're having to scale back the running, or they're not able to run at all, then yeah, I'll opt for 3 sessions a week, and then we might do some cross training on those other days as well. That's not provocative. From a cross training perspective, like try and go the elliptical. That's probably as close to running as you can get. The bike can also be useful. Just the thing you've got to consider with the bike though is the saddle soreness. So actually where the saddle sits on through there, and this is where you can see this in triathletes as well. They're also not just hurting on the bike, but they're hurting on the run, but they're also hurting with sitting on the saddle. And so for some of those, we might actually have to look at for them a bike setup or their bike fit, how to change that and reduce that pressure when they're on the bike. But yeah, cross training if we need to top up, they can't get their normal running in, and we'll try and keep their cardio going as much as we can.
Okay, so you're doing that strength stuff twice a week. You're kind of doing keeping them running, but trying to decrease the intensity. As far as like the store and release, the plyometrics, is that something you're starting right away and kind of putting into the strength session, or what are you doing?
Yeah, I do. I'm a big fan of plyometrics. I mean, a big part of my caseload is calf and Achilles issues. So I do see, a lot of runners neglecting that, and I think there's also some good research now on terms of the performance benefits that plyometrics bring for endurance athletes. So it's not just from an injury point of view, but also a performance point of view. So that's where I can often sell it to them, sell it to distance runners as like, hey, this is not going to just help you with this. It's also going to help make you faster. So I'll often sort of use that as a gateway. It's the gateway drug to get into their strengths, to slot that in. And we might start with, again, like if they've got a particularly angry hamstring tendon, we might start with some pogos and some hopping on the spot there, which is very much calf based, and just to keep them going, especially if we've dropped their running loads back. It's a good way just to keep the rest of their body going, because it's important not to neglect other areas, and otherwise we send them back to running and something else could arc up because they've been poorly conditioned. So we try and keep that going as much as we can. So starting with more those vertical, then going on to things like with our box jumps and lands, and then starting to go more into those broad jumps and bounding triple hops, hop for distance, those sort of things there to get those hips really really working.
The so the two big ones that's to me is like the Achilles with the distance runners, Achilles, and then I guess now the hamstring. Is there any difference you've seen in the time these people can take to come back to sport? Or is it too variable?
It is very variable, but we're talking long time. Like it's months, not weeks. For when we're dealing with tendinopathy, and Even like Karen Silbernagle's work showing that, that just the prolonged period of time that this can take, and, recovery is usually over 12 months to be pain free. I mean, I always sort of start with, when I'm talking about, we're talking to my runners with this about how long this is going to take. I sort of say, look, at the moment, this is getting in the way of your running, and the pain is, is high. What we want to do is we want to initially get that pain down, and we might need to reduce your running. But then what we're going to do then is we're going to be building your running up. And if we can see the pain staying below that 4 or 5 at an acceptable level whilst we're building your running, that's a win. And that means what's going to happen is that the pain to go completely down to zero might take us, might take 12 months. It might take months to get that down to completely gone. But you are doing everything you want to. You are, you're setting PBs, you're running races. It's not getting in the way of what you want to do. And so we start to sort of shift their focus from the pain. We start to move it more onto function, because when you're dealing with long-term issues like this, people can just get really caught up in their pain. And, I've seen it as well too, that especially with hamstring tendinopathy and it being so prevalent during their day-to-day activities, you get a lot of people getting into this chronic pain state, and their whole day is just focused around this pain. And, oh, I can't go out for dinner because my hamstring tendon, I can't sit there and with people. And so you do see that occasionally that happen. And so you're really trying to shift them away from, thinking about that pain all the time onto, well, look at what you're doing. This is fantastic. You're now doing this. You're able to lift this weight. You're able to do this exercise. So I try and move them onto doing that as soon as we can, because it is often a long drawn out process, much like the patella and the Achilles. And I've pretty much seen that, like, personally I've seen it with lots of patients, but personally myself, like, it has the duration. I mean, the patella probably was definitely longer, but both have been a good, 4 or 5 months plus of recovery. I can still, if I really annoy go into a really stretch position, I can still feel my hamstring, and I can't do a full reverse Nordic like I used to be able to go flat on the floor and come back up. I can't do that anymore on my patella. My wife challenged me to do it a couple of months ago. I'm like, nah, you know what? I don't need to do that. I don't need to prove. I'm just I'm gonna be sensible. Yeah. So it's long term. Yeah. Yeah. Definitely.
Okay, you said something there that really stuck with me because just before this, I had a call with she's like a professional ballet dancer, and she's dealing with patellofemoral. I had pain for many months, I don't know, maybe years, and then rehab for like 8 weeks, and then just had a big blow up and was just kind of frustrated. And I was just like,
Mm,
this talk of you're seeing this big gain in function throughout the rehab process, but pain is
mm,
like staying the same and like people getting
mm.
frustrated. Is
Yeah.
that what you see with tendons? Is like you
Yeah.
can get these big gains in function, and it's like the pain is just staying the same, and it's just like a delayed thing almost to get it to go down. That's what you're seeing.
Exactly. Yeah, it is. And I like to sort of, either draw it out, or, with my hands sort of saying, we've got a line that represents function. We've got a line that represents pain, and, down the bottom, we've got time. And what we want to see is, early, we don't want to sort of see, like, as you push their function up. So as you throw more exercises or more running at them, you don't really want to see the pain ramp up with that. You want to try and find a level that's going to keep that pain a little bit sturdy, or if they're at a very high pain level, you want to see that even drop down. And then over time, what's going to happen is that you're going to push up, you're going to throw more at them. So that's, you give them more running, more exercise, a higher intensity exercise, and that the pain level might stay constant. And I preempt that. Usually what you find though is that the pain does drop off, but that tail end of the pain can take a long time. And so I sort of preempt that, and I warn them. I say, look, because otherwise what you get is, you get these people that are infatuated on their pain, and they come in and say, well, the pain's the same. I'm like, well, you're running 6 days a week. You're doing 100 Ks versus before, when I saw you were doing 30 or 40. And it doesn't happen often. It doesn't happen often now. Like, I think, I guess, be able to build that trust, with the process. But every now and then you will get them, and so you just have to remind them. It's like, well, this is where you've come from, and yes, the pain is there, but you're able to do so much with it now. And I also do preempt, like, I do like to preempt flare-ups, because they do happen through rehab, whether that can just be again, they've done the same session, but they may have slept poorly the night before or what have you. You don't know the reason for it, but you can just have these blips on the radar where they have this bad day. And what I'd like to do is I preempt that. I say, look, throughout this process, it's never just a smooth line of, yeah, pain goes down, yeah, you're fixed. We will see some ups and downs, but what we'll find is that the downs are, that the pain, the really bad pain is less. Those flare-ups don't last very long. I like to see those flare-ups really within 24 hours. Often we don't need to change anything. It's more like, all right, let's just ride this one through, repeat the same, session or what have you, that following day, and things go back down. And that's like a lot of the flare-ups will do that. Occasionally you can get some big flare-ups where they might last 3 or 4 days, and in which case you might have to tweak things a little bit more with their rehab. Like you might have to skip a session or modify a session a bit more heavily. But I do like to preempt them because, some people just have the expectation it's going to be just they're just going to get better and better and better, and that's that. So yeah, you've just got to warn them that there can be some flare ups, and that hopefully they don't happen, but most of the time they will.
Yeah, that's I get messages all the time of people that are doing like their own rehab and they never know how to
Mm,
process flare-ups. It's like the end of the world for them
mm,
to get a flare-up. So it's like if they could have someone like you
yeah.
or me to talk to. It's so much
Oh
easier
yeah,
to
yeah.
put their mind at ease.
Yeah, and I do get emails from, and I do encourage, like, for because my coaching as well too. I do encourage my runners to coach me, and I'm like, I'll get a panicked email every now and then. It's like, oh, this is really sore. I'm like, okay, let's just see what this goes. See how this goes tomorrow. Contact them the next day. Oh no, it's completely gone. So you can see these things that just pop up. So it's not like, these little spot fires that you don't ignore them. Like you acknowledge they're there, and if they're happening very frequently, well, then there's something that needs to be addressed there. But if it's just this one thing that's happening every now and then, it does settle down very quickly, then you're right to continue on. Um, it should also add, like what we're talking about, sort of that function and pain. Uh, there's definitely a separation there, and in terms of, with Achilles, and I mean, Karen's research has looked at this, and I believe you spoke to her on her when you interviewed her, but looking at how recovery of pain does not mean recovery of function. That you can see in her research. You see a loss of function at, even at 5 years after the time that they've had Achilles tendinopathy, they still fail a battery of capacity testing, and that's where I guess when I'm discussing with my runners and seeing someone in clinic, I do ask about their previous injury history, because if they've said to me, I've got a previous history of an Achilles tendinopathy or a hamstring tendinopathy, you bet that I'm going to be doing some capacity testing on that, because inevitably you find that, well, yeah, you're still 20% down in your strength on that side. Like you've managed to settle the pain down, but you potentially hanging on by a thread. And I don't use those words, but in the back of my mind, I'm like, oh, you're sort of playing with fire a bit here when you haven't really restored that strength.
Mhm. You said so something earlier. You was talking about the when you doing the balloon method. You kind of use that for tendon, but then like you're also doing something for muscle. And I've never, um, I guess I've probably kind of thought of that, but like yeah, the way you said it was kind of new to me. So you're doing that really heavy ISO to try to get some like tendon stiffness adaptation, and then for the muscle, you're just doing like normal whatever hypertrophy rep range, right?
Yeah, 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 and I guess you can never separate them like that because they're connected, right? That's
Yeah.
but I think, and yeah, for me, I think that penny drop, like the way that I've explained it, was how I heard. I think it was Aaron Patsis maybe on one of his interviews, I think, but talking about, yeah, how you can, yeah, the different training modalities can target, I guess, different components. So that's sort of, yeah, how I've I guess, evolve my practice to do that, exactly that.
I didn't. Aaron Patsis has an interview.
I think it was Aaron Patsis. It may have been. It's definitely one of the group. I'll have to look it up. But I love listening to podcasts, and it's funny actually talking to you, because I usually listen on 2 times speed when I'm out running. So how you're talking now is quite slow. How I'm used to listening to it at 2 times speed.
Yeah,
So when I'm out on a
yeah.
run. But
um,
I'll look that up actually. I'll see if it was. Make
yeah,
sure it
okay,
was Aaron
because I
Patsis.
was
That
only aware
yeah.
of Falk Mersman has been on. He's been on
Oh,
mine, and he
actually,
was
no,
on.
no, no, no. It was Mersman. Yeah, yeah, yeah.
Okay,
You're right. No, it
okay,
was Mersman. Sorry. Yeah,
yeah,
yeah, yeah.
yeah,
Yeah, yours and Greg's. I think it was. It might have been one of the two. But
uh-huh,
yeah.
yeah. So, something you wanted to bring up here was these people with the proximal hamstring, the runners. What effect does running technique have on? Yeah.
Yeah. So running technique is also another one that we're looking at from their assessment, and there are a few sort of things that we see that will put increased load on that proximal hamstring. So, firstly, there's looking at trunk position, so an increased forward lean that will put more work in through that posterior chain, and there's been some good work that's been done by the JB Marines group there, looking at the pelvic position and that strain on the proximal hamstring tendon. So I look at that. So we look at to make sure that they're not flexing forward. And often you do see when runners fatigue, especially more recreational runners, they do tend to, as they fatigue, they do tend to flex more forward, and so that can put more strain up and through there. So that's one component we're looking at. The other component we're looking at too is the is looking for overstride. So that's where their foot is landing at initial contact is more forward of their center of mass. So if you think of that, I mean that again results in an increased hip flexion range, and if you combine that overstride with an increased forward trunk flexion, and that does sort of a bit of a double whammy on that proximal tendon. The other thing we look for in terms of pelvic control is looking from a frontal view. So usually looking from behind, and what we're looking for there is that pelvic drop. Chris Brammer's done some work around through that, and so we're looking for that excessive pelvic drop in the frontal plane there, having an influence on that hamstring. And then the last thing, I like to use the kickback test, which has also been done. That's part of the SMAS testing that Chris has done, and the research has been done on that. And that's, even though it's been done around sprinting. And sprinting and distance running are obviously quite different, but there is, like, in terms of the recovery and what the leg is doing in recovery, I do find that is something that I'm looking at as well. So you'll tend to see some runners that really just their recovery. So when the foot's in the air, it's just really trailing out a long way behind them, and what that does is. With putting that hip into extension, and also then increasing that lumbar lordosis, so increasing that anterior pelvic tilt, then can put some pressure on that opposite proximal hamstring. So that's something I'm also looking for. So we're looking for trunk flexion, we're looking for overstride, looking for pelvic drop through there, and then we're also looking at that what the leg is doing in recovery, to make sure it's not just hanging around out there to put opposite stress on the other side. Actually, we should mention, just whilst we're on that, actually, with a table testing, and we touched on it before about runners are generally very poor in their flexibility. Like, if you ask a runner to do a toe touch, some of them can only get down to their mid shin, and they're generally quite poor in that posterior chain. And it actually is a performance benefit for them to do that. Like, there's been a few studies that have looked at that flexibility in runners and found that those actually less flexible performed better, like they had better running economy. And so, yeah, your typical sit and reach test or your active straight leg raise, you often will see that decreased in runners with or just in runners in general. So it's always something I'm never trying to push that to try and improve that, but just know that that can have a result then if they're really sort of, I guess, more wound up, whether that potentially can put more strain on through that proximal tendon area. I'm not a big fan, so obviously, of stretching that for runners, and especially for those with proximal hamstring tendinopathy. Stretching is certainly not a big part of this, because it just tends to piss it off, like it does for in other tendons around the body as well. So looking at that, whilst we're also looking at that flexibility, I do also want to look at their hip extension range. So if they do have a loss of hip extension on the opposite side, then that can be putting pressure on through through the opposite hamstring tendon. So definitely want to be looking at that as well. Is there the hip extension flexibility on the opposite side?
Hmm. So when you have that running technique, that's like kind of compensating or working around the pathological area. What are you doing? What kind of advice are you giving for them?
Yeah, so in terms of queuing for that, and depending on what they're doing, like the if it's trunk position, just encouraging a more upright trunk. So you never want to see perfectly vertical for distance running. You're going to see usually a 10-degree forward lean is what we want. So if we're seeing any excess of that, like 15 or 20, then we want to try and bring that back to 10. So that can just be encouraging a more vertical trunk. So that can be imagine you've got a string attached to your head and it's just pulling you up taller. So encouraging that. I don't like to use cues that, tighten this, contract that. Like, I don't like that. It's not very efficient to do that. And yeah, even if you say to someone, oh, brace your core when you run or contract your glutes when you run, it's just, it's never really made sense to me. And once you start doing that, you start throwing out other things. So I don't encourage contraction. It's more about just position awareness. So just being tall and for the trunk. If it's overstride, there's lots of ways you can do that. You can either verbally tell them to cue them to a shorter stride, so not landing so far out in front, or you can use things like manipulating their cadence, so their step rate. You can use a metronome. So if they've got a low cadence and they're landing a long way out in front of themselves, you can tell them to, all right, we're going to increase your cadence by 5 or 7.5%, and get them running to the metronome there. And you usually see that will start to they'll start to shorten their stride as a result of that. And you'll also tend to see that can also help with that pelvic drop as well too. Because when we're seeing that pelvic drop, sometimes if they're really landing a long way out in front of their center of mass, they're almost like overreaching, and that can then cause that to drop down. So sometimes simply by getting them to increase their cadence, we can work on that pelvic drop. Leg recovery, that can sometimes be solved again with cadence, and that's where cadence, manipulation can be great, because you can do so many things with just one simple cue. Otherwise, that's encouraging them to, use a combination of their hip flexors and their hamstrings to really bring that leg through into recovery. Or it might be working on some drills, like just simply some A marches, some A skips, some leg cycles, just to sort of get them used to what that leg should be doing in the air, and pulling that leg through, so it's not hanging around out behind them. So using a combination of some cues and some drills to help retrain those issues if we find them. I tend to find, like, it's probably not in terms of gait retraining, like for certain conditions, like things like patellofemoral pain, sometimes with shin pain as well. You can often see like an immediate reduction in pain. Like you give them a cue, it's like, oh, that was like a 6 out of 10, and now it's like a 2. But tendons, I haven't found that same sort of miraculous result too often. Like same with Achilles, I think it's like it's a part of it, but it's not like the magic fix. It's like, oh, just do this and your pain will be magically gone. So yeah, that's probably my experience with tendinopathy and gait retraining. Yeah, is that it's not, well, maybe more likely maybe around through the patella. I've probably seen some patella tendinopathy, seen some quick changes there, but the Achilles and the hamstring, I'm finding it's like it's a part of the puzzle, not the magic fix.
Why do you why do you think that is? That
Why?
you yeah
Yeah, I thought
you
you were going to
change
ask
the
that.
technique. Yeah, you change the technique, but you're not going to see a change in the. Is it because like
Uh,
I think of the Achilles, like there's no way around like offloading the Achilles when you're. I guess you can heel strike, but it's
no,
still got to
that's
go through. You know.
and maybe that's why, like maybe that's where we're looking at like the percentage of change that you can get, like percentage of change you can offload. Like I think you can increase and decrease the load around the knee and a lot greater by manipulating things like step rate and cadence. Whereas perhaps around the Achilles and the hamstring, we're seeing smaller percent change. So we might see like maybe a 5 or 10% change, by working on these things around those two areas. Where the knee, we could be getting upwards of 20%. So maybe it's more likely that, yeah, that we can do more around the knee to influence it. I'd never really thought about that. So that's that's yeah, I would probably think that might be more likely the case. Actually, it's easy to change around forces around through the knee and create more significant changes there.
As far as so you said earlier the lengthy time frame of this rehab, and I can assume people get impatient and they want to start injecting or doing shockwave and stuff. What have you seen
Yes.
for these proximal hamstrings?
Yeah, we've certainly seen those. PRP, it's a fairly big one over here in Australia that's still being done a bit. I've had it all. I've seen, not me personally. I haven't done any of that, but I've seen a number of runners that have done the PRP, the cortisones, the stem cells, the shockwave. It's an interesting one. I know there's some research being done at the moment by Aidan Rich over here, is also in Melbourne. He's looking at the influence of shockwave and on hamstring tendinopathy. It wouldn't surprise me if, like similar with Pete Malliaris's group's recent study as well too, that we find that, like there's probably not as big an impact with this sort of condition, that we might see some that has an influence on pain, but whether that's placebo or whether that's the mechanical effect of the shockwave. It's I've seen a pretty mixed result. Like it's pretty rare that I'll send someone off for shockwave for hamstring tendinopathy. And look, I guess it's also, I mean, we see each other's failures, right? Like, say, I see people that have come to me that have tried shockwave and it's failed. But in saying that, there's probably plenty out there that have done shockwave and found it really well, and I don't see them. So, yeah, it's one of those things where I'm not readily referring off for them. And the same with sort of injections as well. I guess if we're getting really desperate, like if we've got a race that's coming up and we've just got to get through this, then that's when we're looking at sort of pharmaceutical means like oral anti-inflammatories or potential injection there. But it's yeah, thankfully very rare that we do that, and it's never injecting into the tendon. Like our sports physicians and doctors over here are pretty good with that. Like we don't, the people are not doing that anymore, thankfully. So. But sometimes it can be used, I guess, to cheat. But it's rare that we'll have to use that. So yeah, and the research is pretty mixed in it. There's only been, I think, a couple of studies that have so far looked at PRP and shockwave on hamstring tendinopathy, and it's not really. There's nothing to say. Oh wow, this does everything. So yeah, I don't. It's not a common thing that I use in my management for this.
Mhm. Are there any? I'm thinking of other adjuncts, like with the Achilles, you have those heel wedges, and they have like those nitroglycerin patches. I guess there's
Yep.
some research on that. Is
Yep.
there anything for the proximal hamstring?
No. Other than with the sitting, like, with cushions and pillows and that sort of stuff to get the pressure off from that, I've never actually used triglycerol nitrate patches for this issue. I don't see that there would be an issue with it, but I've just never actually seen or heard of it being used for this. But no, in terms of any sort of orthotic device, again, where it's more about, yeah, with the pillows and getting the pressure off on that area. Um, so I readily use, heel lifts for Achilles issues. It's the same, I guess, with patellar tendinopathy as well too. Like we probably don't have like maybe some taping around through that might be able to, like, your traditional Chopat braces. Like anecdotally, I've seen some people feel better with that, the patellar tendon strap around there. Some people swear by it. It's like, oh, I've got to wear this all the time, otherwise my knee blows up. Okay, if it works for you. But the hamstring tendon, no, not so much. And again, like with taping, it's not a thing I do around there. Like again, you've got it's a bit of a sensitive area. You've got hair around there, which you have to shave, to shave off in males and females. So taping's not really a big thing that I do around the hamstring tendon. So I don't tend to use a lot of those ancillary stuff actually. Soft tissue therapy, I will do, like again, manual therapy around through there. Like I think that can be a good thing. Like even with, and even though it's not doing anything to improve the tendon tissue around through there, it can certainly help with pain and help to relieve things. And I've seen, you see that happen where you do some manual therapy around the area and people are like, oh, that just feels better. And so yeah, that is a part of what I do. And but it's not the thing that's gonna fix it. And the same thing, like doing again manual therapy around through that lumbopelvic area. We know the connections between that area and and the hamstrings, and so getting good function around through that area can also help it too. So that's where again we've got to zoom out and have a look at the whole person, and working on that kinetic chain. So making sure it's not just all about the hamstring, but making sure we've got good hip strength around through there, good trunk strength, good lumbopelvic function. So that's all a part of my assessment to see, all right, Jake, yeah, for you we need to work on this, and this. But someone over here might just have, well, these are all great, but we just need to work on this for you. So I try and, I guess, subtype, and that's where I like the research that's been done on the Achilles, and subclassifying these different groups where you've got maybe more load management in this group, you've got a lot of psychosocial factors in this group in here, and then over here you've just got a lot of functional deficits, and so we basically customize the rehab to each individual person.
Okay, I guess going on that further, I was going to ask on, we talk so much about distance running, but you get these proximal hamstrings in field sport athletes like soccer, rugby. What differences are you looking at for the rehab?
It's harder. Like it's a lot harder with a distance athlete. Sorry, with field athletes, because with gym, when I'm dealing with this with gym athletes and also runners, you can pretty much control everything. You can control the weight, you control the reps, you can control the volume, everything. Whereas in field sports, it's a lot harder. You've got and anticipated movements. You don't know exactly their distances they're going to be doing, their high speed efforts they're going to be doing in the game. So it is a lot harder to control in that regard. You can control their training during the week, so you can sort of limit them and saying, oh, we're only going to do this much volume during the week. But when it comes to a match situation, and they're playing, it's difficult. Um, the rehab's sort of still going to be the same. Like you're still going to be working on the deficits that you find, and improving the strength in through that hamstring tendon. But the training load gets a little bit more difficult to manage, especially on match days. And you may have, for really bad ones, you may have to be saying, oh, we can only play half a game, or three quarters, or what have you, or we come through the reserve team where we can control that a little bit more. But yeah, you've got to be across it, and that's where it gets a bit more complicated. Whereas yeah, running and gym is a lot more easy to control those variables.
So I think I have one guy on Instagram. He's been messaging me for years. Distal hamstring tendinopathy, and I
Oh
really
yeah,
never
yeah,
have anything useful for him.
yeah, yeah.
Yeah, have you seen this? What's going on there?
Yeah,
What's the
yeah,
difference?
yeah. You have. I mean, you can see probably the more common area you see distally. So it is rare. The more common one I see distally is actually the pes serene, which is the on the inside of the knee there. So it's a common differential that we see for medial knee pain. So on the inside there, and it's basically where you've got it's a meeting point between the sartorius, the gracilis, and the semitendinosus. You get these three tendons that come down and attach into the inside of the knee there, and that can be a source of irritation, and it can be quite painful around that medial knee there. The management for that one, we'll talk about like distal biceps fem tendinopathy in a sec. The management for that one, I will look at again hamstring adductor function, so getting that right, and also manipulating running loads there. That one I find is relatively easy to settle down. I think it is more a bursa, and I haven't seen anything on like looking at a histology study of those sort of conditions. Like, are there actually changes in the tendon, or is it just an irritation of the bursa from like a reactive tendon? I seem to think I reckon it's more that. I think it's more a reactive tendinopathy that just irritates the bursa. So you can often calm them down a lot quicker. You can see recurrences of it, but I've never seen someone have that persistently for like, a year or years like you see with your other tendons. Distal biceps fem, so that's more where it's on sort of the lateral part of the knee. It is pretty rare. Like I reckon it's probably been, a year or so since I have seen one of those. I would approach that in still the same ways. You may be looking at more like from a running point of view, more knee-based positions that could be influencing that. Like you're still going to be seeing from a running technique point of view, like overstride is still going to be putting like landing more with an extended knee is going to be putting stress on that distal biceps, potentially some compression through there. But you still want to ensure that they've got good hamstring function. Again, like I wouldn't see why you wouldn't do, using the Berlin protocol as well for that distal bicep. So they're probably the things I'd see different. You're not going to have with the distal biceps, you're not going to have it the symptoms you will proximally in terms of, pain on sitting. Like there's not the compression factor that through there. So it's sort of a little bit easier to manage in that regard, that it's usually just, purely exercise related, or running related that you want to be working on for that.
Mhm. You said earlier during the COVID time, you had people come in with like non-load related, and I kind of
Mm,
want to ask about these. I don't know if it was Greg Lehman or someone like talking about these metabolic tendons, like the insertional
mm,
Achilles or like their maybe
yeah.
rotator cuff, lateral hip, and then I thought they put proximal hamstring in there. Is that one of them too? That like I guess can these metabolic issues manifest in any tendon, but it's like maybe they're more
Yeah,
likely in
yeah.
certain ones. So it's like, is it more
Yeah.
likely in something like a proximal hamstring?
I haven't heard of it more likely in any. I've seen it. I've seen it happen in all, with metabolic conditions. Like I've seen, I think was it Derek Griffin? I think was on your podcast. I think was talking about that. But the I haven't seen it affect one more than the other. You tend to see, certainly, like I've seen things like, so from a metabolic condition, insulin sensitivity, diabetes, changes in cholesterol medication can trip off any tendinopathy. One that you do see quite often, which is a really frustrating one, is perimenopausal women. So, changes in estrogen levels there can trip off any. And I do tend to see, like, certainly you see the gluteal tendon, like that's a really big one, in terms of I think the prevalence. I remember seeing a stat recently from, I think it was from Alison Grimaldi, like it's really high. It might be like 50 or 60% of women going through menopause will get some, lateral gluteal tendinopathy through there. So, and with that, I do tend to see that the hamstring tendinopathy is swept up in that. Like I've got a lot of runners that are perimenopausal, so that are sort of in their 40s and 50s, and they do have, that there is a hormonal contribution from their hamstring tendinopathy. So, and it does get hard to manage. And I've had runners where they've just, like, they're going through menopause and they just get tendinopathies popping up all over the place. Like, 1 month it's like I've got a, patella tendon, and then 3 months later, oh, now it's the Achilles that's popped up, and so they're just, and then it's upper limb, like I've got rotator, extensor tendinopathy, like it just spot fires going on everywhere. And I mean, you're still, like, again, that's it's almost a process of, right, well, look, this is what's happening with your body. This will settle down. The other influence, well, the other thing to potentially consider there is HRT, but that's not something obviously I deal with. I send them to their medical doctor to discuss that. And I wouldn't be giving it to them just for their tendons. It would have to be for, other things that are going on in their life as well, and other symptoms that they're getting. But yeah, hormonally, I tend to see that being a trip there as well. But no, I wouldn't say it's more common, like, that there are, yeah, sort of more that are prone to that metabolic contribution.
Um, all right, for people listening, made it this far, we sat down off air and you said maybe we should do a show on proximal hamstring tendon, and I was like, yeah, let's do it. So I have to ask you, do you think we've covered everything you think we
Yeah, I
needed
think
to
I think
here?
we have. I think we've gone through the differentials. What we're considering. Some of the things that we want to be considering in our management with a load. Load management, our rehab, our running gait analysis. The lifestyle factors through there, which are all pretty important. So I think we've hopefully done it justice. So our listeners might think otherwise, but I think we've done well.
Yeah. I wanted to ask earlier. I've been asking all these guys I've been getting on shows with is if you could going back to when you first started in this field working with
Hmm.
people, what was your tendon knowledge? Because like you have quite a bit with Achilles, patella, proximal hamstring. How did you develop this knowledge base? Was it just years of working? Was it research? What was it?
I have got an obsession with I guess continuing development, and I guess trying to improve myself. So from a very early, and even during my university days, I was taking a lot of courses, and getting exposed to lots of different professionals and approaches, and that is something I found that really helped to shape me. I probably went early days. I probably did too much. Like sometimes when you're just learning and consuming so much information, you're not applying it. And so, it's almost like in and then out. So that's something I eventually actually, learnt to slow things down and say, all right, I'm going to now, how am I going to apply this, what I've just learnt? And even when I'm listening to podcasts now, like I'll, sometimes pause and I'm like, all right, well, how does that influence how I'm practicing? Does it confirm what I'm doing, or is it something I need to change? So I sort of a bit more reflective now than what I used to do, which is just like, just give me information, give me, give me, give me. So I do like to, I've always invested a lot of that time into myself, and I love learning from, different professions and different approaches. So it's not just an echo chamber as well, but sort of, I guess, questioning and the way that I do things. So my knowledge when I first came into the profession was quite low. Like we had to learn, you learn lots of things when you're going through uni, and my knowledge of hamstring tendinopathy was zero. It came through, again, just getting more involved in runners and seeing more of it. Then I'm like, yeah, I do need to learn a bit more about this, and that's when I sort of delved in to learn as much as I could. And there's still lots more.
How do
And
you
it's that's the Dunning-Kruger effect, that the more you know, the more you realize you don't know. So that's why I'm always love learning, because I know there's so much more to know in this game.
do you think that you having the patellar tendon, Achilles, hamstring, uh, for me, I've had the patellar so much, and I'm like, it's so beneficial that I can work with people, but it also gives me a bias that could be very negative because I only have my experience. Do you feel the same with yourself of like you've gone through these things, but it's like it could be so individual to you that you're
Yeah.
looking at things differently, you know?
Yeah, I think, look, does it help? Yeah, look, I think it does. I mean, it's the same thing as like, does it help me being a runner to treat runners? Like it does help, and much like, you can dunk, so it helps others, to, I guess, gain some respect for what you do. But it's not necessary, so long as you've got a knowledge of what people do. So I think it has helped me. But I mean, the hamstring tendinopathy, I've been managing that for, I mean, myself, it was only last year that I suffered from that, but I've been seeing these for, 19 years before that. So did it give me, look, yeah, it probably did help, but it wasn't necessary. And I guess I've seen now for long enough that everyone is different. It's that, what I say is the N of one. That person coming in your door, they might have hamstring tendinopathy, but they've got a whole different set of contributing factors. And that's what I love doing what I'm doing, because it's never the same. Like it's always I'm like the detective, and we're just trying to talk about, well, why has this happened for you, and therefore how do we need to individualize the management for you. And that's unfortunately where I think some of the research does get. It's hard, because you're getting, groups in a lot of research studies, you're getting groups of heterogeneous people that have got all mixed contributions, and you're throwing an intervention at them, and then hoping that works for the whole group. So I think that really individualizing is crucial for health and fitness.
Yeah, the limitation of research.
I
Um,
know, yeah,
yeah,
yeah. And I
it's
think we
like
acknowledge that. Like we need it. We need it. It's and it answers a lot of questions, but there's things that we'll just never be able to answer. Like I always think of, we're going to crack the running injury code, but it's just, there's just so many. It's multifactorial. Hopefully, with the evolution of AI, we might be finding something that's going to say, Jake, you're going to get injured tomorrow, so please refrain from running. That we're so far off from that at the moment. That from a prevention point of view.
yeah, yeah. All right, Luke. Tell everyone where to find you. In
Yeah,
person, online.
yep, yeah, absolutely. So I'm on Instagram at Sports Chiro Luke, also on LinkedIn. I'm on Twitter or X as well. But people can usually most contactable through Instagram. That's where I like to spend most of my time. It's a good platform. We've got a good yeah. There's a good community there. Lots of people to learn from. I've actually just recently done a hamstring tendinopathy course for clinicians on learn.physio as well. So that's going to be coming out pretty soon, actually. So if people want to learn more about that and the practical ways of diagnosing and managing it, then they can also look that up on learn.physio.
I didn't know that. All right, man.
Yeah,
Thanks for
yeah.
coming on.
Thanks very much, Jake. It's been a great to chat to you, and yeah, look forward to keep up the good work, mate. I'm loving the stuff you're putting out. So looking forward to more to come.
Thank you.
Cheers, mate.